Okay, ladies and gentlemen, welcome to the heart lecture. Glad that everyone is attending. I will put this on Zoom and we'll go from there. Let's start with heart. If you open up to page 476 of your textbook, that begins your heart readings and the pictures. And if you look at the image on figure 13.5, you see the heart and all of the vessels that are associated. Make a fist and, don't go like that to me. Make a fist, put it right here. The heart is fist-sized, right? Anterior to the sternum, and it's about 1 pound in weight. It has, as you remember, muscle. Heart is made of muscle, and if you look at my fingers, the heart muscle looks like this under the microscope. It's branched, giving it greater strength. The branches have intercalated discs, which are desmosomes and gap junctions to give it strength. And that is just a mini review of the microscopic structure. Okay, so there's a lot of strength to the cardiac muscle cells. The coverings of the heart are as follows, all right? Let me talk first about coverings. Your lab, I sent you 2 labs this week, heart and blood vessels, right? You should know the structure of the heart. There's 4 chambers, 4 vessels, and 4 valves of the heart that I'd like you to be sure to know. And then around it, around the heart's got the 2 coverings, the fibrous pericardium and the serous pericardium. The word peri, or the prefix peri in Greek, means a surrounding. So whatever surrounds the pericardium. And anyway, the outer layer of the pericardium is fibrous. In other words, a lot of fibers made of dense connective tissue. And that is mainly for protection. So the outer layer looks like almost like saran wrap. And if you look at the video that I sent, it's a saran wrap of the heart. The next layer is the serous pericardium. And the serous pericardium is the inner layer of, let me show you a picture here, the inner layer of the pericardium. Oops. I don't have that here. Sorry about that. If you take a look on figure 13.6, the structure of the heart is given. And the 2 layers of the serous pericardium are as follows, the parietal and the epicardium. Now, the parietal serous pericardium lines the inside of the fibrous pericardium. Do you know what I mean? The fibrous pericardium is on the complete outside, and right underneath that is the parietal layer, all right? Directly covering the myocardium, myocardium is another word for heart muscle. You can write that next to it. Heart muscle, myocardium. So when you have a myocardial infarction, that's a heart attack of the muscle. The epicardium is the layer that surrounds and is right on top of the heart. And it has all of the blood vessels that hold the blood going to the heart. So it's directly on top of the heart and supplies the blood to the heart. That's what the epicardium does. There's also an endocardium. Endocardium means inside. You got to line the inside layers. So there are 4 different chambers. Those chambers have to be lined with what we call an endocardium. And the endocardium is made up of simple squamous epithelial tissue known as endothelium. So those are the layers of the heart. The lab manual will show you a nice image of those different layers. That'll help you to visualize. The chambers of the heart are seen on figure 13.6, page 478. And the relationship of the heart to the lung is shown in figure 13.7, all right, page 479. Let's go over those. There's 2 chambers of the heart that are very small and on top. They're known as the 2 atria. There's a left atrium and a right atrium. And they're small, thin-walled vessels. They are the receiving chambers for blood for the heart. And they send blood to the ventricles, all right? Now, I told you again, there are 4 chambers, 4 valves, and 4 general vessels going to and from the heart. So these are the 2 top chambers, the left and right atrium. And again, on figure 13.6, if you look, the blood flow is shown from the left, from the right atrium down into the right ventricle. All right, and so that brings us to the ventricle. The ventricles are the 2 large chambers at the bottom of the heart. They do most of the pumping activity, all right? If you take a look, that's where most of the muscle is in the heart. And okay, let's talk about the different vessels coming to and leaving the heart. What I think I'd like to do, make this a little bigger. And let's get heart structure. I just want to show you, YouTube structure of the heart right here and now. So we can, any visual works well. I think this one is nice because it's kind of simple and clear. Take a look up here. Okay. Here's the heart. I just want to go over the pumping capacity and how it works out. Okay, everybody, hopefully you can see that. We're going to trace the flow of blood as it moves through the heart. Blood flows from the superior and down here inferior vena cava into the right atrium. That's the first chamber. These are veins. Veins are large vessels that accommodate and bring generally what we call deoxygenated blood, as we talked about in the last lecture, less oxygen. And that's generally noted as blue in color. Oxygenated blood is noted as red in color. And the blood flows into the right atrium. And then here is a valve. A valve is a one-way door. It is allows liquid one direction and closes once it goes through. So as pressure builds up in the right atrium, everyone, blood flows through what we call the tricuspid valve into this chamber known as the right ventricle. Notice the walls here. These are thick. Thick walls mean a lot of pumping capacity. And that pumping capacity pushes from the right ventricle blood through the pulmonary semilunar valve, through the pulmonary artery into the lungs. These arrows go to one lung and that another lung. Left lung, right lung. The pulmonary artery. That is the next vessel. Blood gets oxygenated, obviously, in the lungs, and blood is brought back in through the pulmonary veins. Pulmonary veins receive blood into the left atrium. There are 4 pulmonary veins. That's your third type of vessel. And this is your third chamber, the left atrium. Notice red or oxygenated blood. The left, that's to the left atrium. This is the mitral valve. And the mitral valve, one of the most common to leak, by the way, because there's a lot of pressure here. The mitral valve is also known as the bicuspid valve, and the blood flows through it into the left ventricle. The left ventricle is what has most of the pumping capacity of the heart, and it pushes blood out into the aorta, and the aorta sends blood to all parts of the body. That is the general structure of the heart. All right? Okay. Now here is the notes for what we just talked about. We're tracing the flow of blood through the heart chambers. The atria know where they are. The ventricles know where they are. Know where the vena cava is, which brings blood to the heart. Know that the aorta sends blood out of the heart. Know the pulmonary veins and pulmonary arteries. Note that the pulmonary veins are the only veins that carry oxygenated blood in the body, and pulmonary artery is the only artery that carries deoxygenated blood. Why? Because anytime it's an artery, A for artery, write this down, A for artery, A for away from the heart. A for artery, A from away from the heart. Anytime there's an artery, it always moves blood away from the heart. In this odd case, it goes to the lungs, where it's got to get oxygenated. So it's the only kind of exception to the rule of arteries and veins. And so what we did was we talked about the systemic, coronary, and pulmonary circuits. All right, this is cardiac circulation. We break it down. Pulmonary circuit basically is what we focused on just now. Bringing blood from the heart, through the heart, back to the heart, from the lungs, all right? So you're using the pulmonary veins, pulmonary arteries to oxygenate. That's the heart-lung machine, the pulmonary circuit. The systemic circuit is as follows, figure 13.7. If you take a look, it's bringing blood to all parts of the body. So after it's oxygenated, blood from the left atrium, to the body, and then back to the right atrium on the other side. That basically supplies your brain and your vessels of the rest of your body. So that's your systemic circuit. So let me clarify this again. The pulmonary circuit is pretty much your heart-lung machine. The systemic circuit is your heart to the rest of your body and back. So it supplies all of your vessels of all of your body with oxygenated blood. And then there's the coronary circuit. How do you get blood to the myocardium, right? That's the big question. How do you get blood to the myocardium? And the answer is, of course, that the myocardium has to be oxygenated. Blood is useless inside of the heart in its chambers. The myocardium doesn't get any blood from the chambers. And it's a weird thought because, when you get a heart attack, it means you're not getting enough blood to your heart. And then you say to yourself, isn't the heart filled with blood, all the chambers at all times? Yes, but it's useless to the heart. So instead, the coronary circuit arises from the base of the aorta, encircles the heart through the atrioventricular groove, and sends blood through the left and right coronary arteries to branch and form what we call anastomoses, or many fusing vessels. So a lot of blood can flow to an area even if there's a blockage. So those coronary vessels lie in the epicardium and nourish the myocardium. All right, I just want to emphasize that is the coronary circuit. The vessels are known as your coronary arteries, and they supply blood to the heart muscle from the aorta. I repeat, the coronary circuit is supplying blood to the heart muscle from the aorta. When you get a heart attack, it's the coronary artery that is blocked and does not allow for that supply to go to the heart. All right, so we're going to talk a little bit about disease, drugs, and various problems. And luckily, my father had no heart problem. Things are going okay. His valve is, under control. And I just want to say, 1/3 of people will have some sort of heart-related issue, or more actually. 1/3 will actually die of a heart or blood vessel issue. And I just, not to be negative though, there's a lot of things you can do to fight it, from the beginning, diet and exercise, to drugs and surgery. All right, diet and exercise, obviously, walking, exercising, 22 minutes a day of aerobic exercise, which means, Matt Murphy would know this, right? Bringing your heart rate up to, 220 minus your age. So if you're 100, 220 minus 100, so 120. So anyway, and then 80%. So I think that's your maximum target zone. So there, you can kind of look up a chart to see your target zone to get into your aerobic exercise. And you got to do about 22 minutes in order to exercise, get the fat levels down, etc., because fat is related to building up those coronary arteries that we just talked about in the coronary circuit. So let's move on. Number one, is caffeine or nicotine good? I just had coffee this morning. You can feel nicotine, smokers, it creates what we call an ectopic focus. Another part of the heart even takes over, and sometimes that can lead to trouble. Caffeine and nicotine speed up the heart rate. So drugs are very known to change heart rate. Some drugs, cardiac drugs, are used to control the heart and strengthen the heartbeat. And some drugs that we take, like a simple thing like caffeine, smoking, nicotine, increase the rate that our node beats, and we'll talk about that shortly. But let's talk about valves. Incompetent valves mean that they repump the same blood. A heart murmur, when you hear the word heart murmur, that's like a swishing sound of the backflow of blood. And sometimes it's normal in kids or the elderly due to thin heart walls, but sometimes it can be due to, not sometimes, very often, a heart murmur indicates a backflow of blood or a regurgitation of blood. And that is what a murmur means. So when you hear murmur, the average person doesn't understand that that often means that there is some sort of leaking valve, all right? And it's, there's a lot of words for regurgitation, but a leaky valve and therefore backflow of blood. And the trouble with it is that you're really repumping the same blood, everyone, and that is the dilemma. Stenosis of the valve means the valves get stiff due to, age, calcium deposits. Endocarditis is an infection of the heart. That's why you got to be careful with infection. MI stands for heart attack. You can write that down. Myocardial infarction. Myocardial infarction. I should write that. I think I'm going to have that written down right here. That's a heart attack. I'm just giving you a couple of the diseases. So heart attack, myocardial infarction, that's a clogging and a blockage of a coronary artery, which we talked about with the coronary circuit. An incompetent valve is basically a leaking valve, repumping the same blood, weakens the heart over time, can lead to heart failure. Stenosis is one form of that, where the valves stiffen. They treat valves a variety of different ways. Some treatments are a replacement. A pig valve, a synthetic valve, or a dead body, we call it a cryopreserved valve, is placed in. That's kind of a big surgery where you got to actually cut open, do open heart, bring it in. Open heart surgery involves a sternotomy, where they're cutting open the sternum and keeping you on a heart-lung machine. It's a bigger endeavor. The valves last about 10 to 15 years, but they have some new treatments going out where they go up and put, with a catheter. A catheter is a little tube that goes up usually through the groin, sometimes the wrist, but in this case, the groin, and places a valve replacement or repairs the valve. And I won't get into the details of it. The aortic semilunar valve that we talked about often leaks in people, and the treatment has shown very good success through the catheter up instead of cutting open the sternum. So that's a developing area. For the mitral valve, they do have a little clip that goes up, and they're working on getting a replacement. So these are, leaking valves you can live with for a long time, or sometimes they cause a lot of trouble and they got to be replaced quickly. So it depends on each case. Angina pectoris is chest pain due to fleeting blood supply to the heart. It's a warning sign usually. The myocardium's weakened, but it doesn't mean you're dying. Chest pressure should always be analyzed. I mean, sometimes it's gas, sometimes it's stress, but ultimately you want to avoid the heart attack. And so a stress test is given to see how the heart, a person jogs, walks on a treadmill, and the heart is checked with an EKG to see how abnormal the heart is under different levels of stress. That's why it's a stress test. And so you try to detect it before to see your risk of a heart attack. Because the heart attack, once it happened, causes damage. And that damage is most serious because the heart has a difficult time repairing itself, as you know from A&P1. So that's heart attack. That's leaky valves. That's the general flow of blood from the heart to the body and through the heart. I want to talk about some treatments for clogged arteries, because that's an important point. One is the bypass, where they cut open the sternum, as we said, and literally suture on vessels to pass, in other words, bypass the clogged area. That's a coronary artery bypass graft. I have that on page 481 discussed. They also have stents. Stents are little tubes sent in through a catheter. A catheter, like I said, is a little wire that is sent through your vein system into your coronary arteries, where a balloon angioplasty is done, where there's a balloon at the end of that little wire that smushes open, pushes the fat against the wall, and opens the vessel. A little stent, which is a metal tube, replaces that fatty area and keeps it open. In other words, the metal tube keeps the area open where the fat was smushed, and that has better chance of success, so it doesn't reclog. So that's a stent when you hear the word stent, and that's a bypass when you hear the word bypass. Those are the two procedures for opening the vessels. Very effective in doing so. All right. Cardiac physiology, please turn to figure 13.8. That is an EKG, page 480. All right. You've got what we say the heart is autorhythmic. That means it has a pacemaker. 1% of its cardiac cells depolarize spontaneously. What does that mean? That means there's a little part of the heart in the right atrium. I have a little, don't laugh at the picture of the heart. The picture in the textbook is much better. If you look in figure 13.8, figure 1, there's an arrow going from what we call the sinoatrial node. That's the little 1% of heart cells that depolarize spontaneously. In other words, shoot off electric currents. And the rate of contraction is therefore determined by that 1% of cells, and that's known as the sinoatrial node in the wall of the right atrium. If you look in that figure 13.8, number 1, boom, you have the SA node, sinoatrial node, sending an impulse to the atrium. And it's a wave-like nerve impulse that, I guess, hits what we call the atrioventricular node. And the atrioventricular node is here. Take a look at my picture. This is the SA node that I drew. This is the heart, right? The 4 chambers. It's a terrible picture, but I just wanted you to see in the right atrium, right? That's that dot. That's the SA node. This is the AV node. So the SA node, step 1, sends out an impulse. Step 2, to the atria, the 2 top atria here. And then step 3, it hits the AV node. That is the AV node. That AV node, if you look at number 3, sends a message down the bundle of His and up this area known as the Purkinje fibers. As you can see in figure 5, Purkinje fibers then fire and electrify the ventricles, these 2. That's the last phase, number 6, in figure 13.8. All right? So you can see a wave-like contraction. And an EKG is what traces the electrical changes of the heart. Okay? And this, let me show you the EKG. Actually, I have it right in here better than I have here. I don't even really want to go here. Let's take a look. I'm skipping this part right now for a second, but I want to just show you what an EKG is. All right. An EKG always has polarity changes on the y-axis, time on the x-axis. In other words, the SA node sets the beat and sends out the impulse for the heart. And when the atria, when the atria become electrified, we call it the P wave. Atria are depolarized, we say. So make sure you know this chart. Atria depolarized, that means the P wave forms. That EKG detects the electricity. Then there's what we call the QRS wave. That's the ventricles that depolarize. And that's a big chunk because the ventricles are huge. So that's traced in the electrocardiogram in a large wave. At the same time that the atria are repolarizing, going back to normal, you can't see it. That's at the time when the others are depolarizing, when the ventricles are. And then the T wave traces the ventricles repolarizing. That's another electrical event. things going back to normal. So let me repeat that. P wave is the atria depolarizing. The QRS wave is the ventricles depolarizing. And the T wave is the ventricles returning back to normal, called repolarizing. All right. So that shows the electricity of the heart. I want to say that changes in the EKG show different problems. So for example, let's take a P wave. If you don't have a P wave, you can write this word down, atrial fibrillation, or actually I have it here. Fibrillation. Maybe I'll put that in the chat room. Atrial fibrillation equals no P wave. Okay, let me just put that there. AFib is no P wave. You see, fibrillation is out of phase contraction. That's like a functionless heart. That's going all over the place. All right. A wider QRS wave equals heart enlargement of ventricles. That's not a good thing. It means the heart is weakening. As the ventricles enlarge, the heart weakens, and a weakening of the heart indicates what? That the heart can't do what it's supposed to do. And that can lead to heart failure, where it's unable to pump the blood as needed. Any arrhythmia, and there are many types, is known as an irregular heartbeat. Okay? Any arrhythmia is known as an irregular heartbeat. And it can be, there are a whole bunch of types of arrhythmias. Sinus arrhythmia is innocent. You don't have to really worry about it. And fibrillation is you're going to pretty much die. You need to shock yourself with some sort of defibrillator, or you're going to have trouble. I mean, it's a functionalist heart. So it's a very big range when you say an irregular heartbeat. Let me just note that the SA node sets the beat at between 60 and 80 beats per minute. I wrote down 75, but the normal beats are 60 to 80 beats per minute. You know, all you have to do is really, here's how to test your heart. Check your heart rate. Take your two fingers, not your thumb because it has its own beat. Take your two fingers and go right here by the thumb. And that will give you the number of beats per minute. And if you're between 60 and 80, that's normal. That's your resting heart rate. I usually count, and you know, they suggest 15 seconds and multiply it by 4, and that gives you the beats per minute. So let's say I count 15 in the next 15 seconds. 15 times 4 is 60. That's what I get. Now, if you have a problem with the electrical conductivity of the heart, we say that it's a heart block. That means we're blocking some of the electricity. And a pacemaker is what's implanted in order to increase the heart rate. The AV node sets the heart rate, everyone. The AV node sets the heart rate if the SA node is damaged or blocked. And that thing itself beats at 50 beats per minute. If both are damaged, SA and AV node, then the Purkinje fibers set the beat, and that's 30 beats per minute. So, you know, that is what sets the heart rate within the heart. There's also cardiac centers in the medulla oblongata, where there's sympathetic and parasympathetic nerves going to the heart that either increase, if you're sympathetic nerve, or decrease the heart rate and beat, the force of the beat, if you're parasympathetic. So again, I just want to say the heart itself sets the beat, but you know perfectly well if you get nervous, your brain is sending messages to make the heart rate go up. And if you're relaxed and laying around, yoga, deep breaths, you know, whatever, the heart rate goes down. And that's the medulla oblongata that sends out nerves, sympathetic or parasympathetic, to speed or slow up the heart rate. And epinephrine and thyroxine are examples of sympathetic hormones given off by the body to also control the heartbeat. Epinephrine and thyroxine both increase the heart rate. Okay, they're both hormones that we talked about that increase the heart rate. And this is just to give you a little remembrance of that. right? Your cardiac output is defined as, really gives you how healthy your heart is. How much blood do you pump out by each ventricle in 1 minute? And how you figure that out is you multiply the heart rate times the stroke volume. Or what does that mean? The heart rate is your beats per minute. That's what we just figured out. And your stroke volume is the amount of blood pumped out by the heart, in other words, by one ventricle per beat. And if you have what we call an echocardiogram of your heart, that is they use echo waves to get it kind of a 3D picture of the heart to see how the blood flow of the heart is going. And I want to just say that the ejection fracture is the most important part of the echocardiogram. Again, let me repeat, the echocardiogram shows the blood flow. I guess it's less 3D. It's more or less showing the blood flow. It's a little 3D, and shows how the heart's functioning to get blood in and out. And the ejection fracture is how much blood is pushed out of the left ventricle. That is the ejection fracture. So if that ejection fracture is too small, like less than 50%, 50 to 70% is normal. Less than that, then the heart's not pumping properly what it should. So the amount of blood pumped out by the left ventricle per beat is known as the stroke volume. All right, it's known as the stroke volume, and the ejection fracture is how much is coming out of that left ventricle. To make a long story short, what is cardiac output? How much is put out by the heart per minute? In other words, the left ventricle. So it's heart rate times stroke volume. I know that's a long-winded answer, but anyway, our example is 75 beats per minute times, let's say the stroke volume is 70 milliliters per beat. That's how much you're pushing out per beat. Times it together, it's 5250 milliliters per minute. That's, a general rule of thumb of the normal, just general rule of thumb of the normal adult cardiac output. We say that cardiac reserve kind of tells us how healthy a person is. If you have a lot on reserve, like if you can get the cardiac output up a tremendous amount, you're athletic. That's equal to like 7 times the resting. If you're non-athletic, then you can only get the output up 4 to 5 times the resting. So this is the resting. So imagine 7 times this, 35,000 milliliters per minute. That's a ton of blood pumping through. You have to keep that in mind. We're very exciting, dynamic creatures, and we have a lot of things going on all at once. If you want to really determine how well your heart's doing, there's 3 factors that determine cardiac output. Number 1 is the contractile strength of the ventricles. How strong is the ventricle? And as I said before, that's measured by ejection fracture. You can even put that word next to it. I'll put that in the chat room because it's an important word to remember if you're in the hospital. People will be impressed. Your ejection fracture is how much is pumped out of left ventricle per beat. Okay, let me repeat. That's a determination in how efficient your heart is. The more you pump out, the better off your heart is functioning because it's getting everything out. That is a strong indicator for the contractile strength of your heart. How strong is your heart ventricles? And the ventricles do most of the pumping. Keep that in mind, everyone. It's not, the atria just receive. They do a little bit of pumping, but they just receive. Then we have afterload and preload. Let's go to preload first. Preload is how much the ventricles can stretch to hold, how much is accommodated in the heart. If you have a fibrous old heart that doesn't accommodate the liquid, then it has bad preload. Afterload is often mainly determined by the low number in your blood pressure, diastolic pressure. In other words, how much pressure is in your blood vessels at any one time to prevent the heart from pumping blood out the aorta. So if you have high blood pressure, that limits or hurts your afterload. It makes a higher afterload. In other words, after you pushed out from the heart, you still have pressure on the heart. That is the big problem with high blood pressure, and it makes the heart work harder. So let me repeat these. What determines your cardiac output or your strength of the heart? Number 1, Obviously, number one is contractile strength of the heart. How strong is the heart? Number two is afterload. How much pressure is still on the heart after you loaded and sent out your blood? In other words, it's your hypertension. How much blood pressure is on your heart? And then there's preload. How much the ventricles can actually stretch to accommodate fluid to get the blood out in the first place. So this is all part of your cardiac output. Talk about disease, just to go over a couple of things. Myocardial infarction is another word for heart attack leading to cell death. Tachycardia is a term used for having a fast heartbeat, all right? Well, over 100 beats per minute, you're going to be tachycardic. Tachycardiac is fast heartbeat. Bradycardia is less than 60, a slow heartbeat. In athletes, you can have very slow heartbeats because you're in great shape, the heart's really strong, great ejection fracture, great cardiac output. Heart doesn't have to beat too much per minute. But if you are instead someone else with a heart problem, an electrical problem, and you have less than 60 beats per minute, and it's not doing the job, that's not good. It's bradycardia. So bradycardia is not necessarily a good thing, okay? It may require, a pacemaker, or may require drugs. Depends. Angina pectoris is just a simple term for pain in the chest. Pectoris, as you know, pectoralis major. Those are your pecs, your chest. Angina is lack of blood flow to it, so it causes pain. Congestive heart disease or congestive heart failure is defined as low cardiac output. Arterial and edema or swelling is the main indicator for that. Arteriosclerosis is narrowing of the blood vessels. The word ischemia means lack of blood flow to an area, and stenosis is another word for narrowing. So arteriosclerosis is known as narrowing of the blood vessels due to fat deposits. I'm going to talk about that in a second, due to fat deposits. Stenosis is a narrowing. And, blood pressure, heart attack, drugs, different diseases can all lead to congestive heart failure. And those are the risk factors. Leaking valves, anything causing less efficiency for the heart. Last but not least, I want to talk about blood tests and some drug treatments for the heart. First off, your blood test should always give you not just your total cholesterol, which everyone write that down, should be less than 200. All right, let me put that in the chat room. Total cholesterol less than 200. I always like to have that as a golden number. 219, I don't know, there's some variation, but 200 and less, okay. And HDL, put a smiley face next to H, smile, and say happy. HDL is your high density lipoprotein, or your happy fat. That should be higher than 35 because it's supposed to remove or keep fat from building up on your blood vessels, on especially your coronary arteries. L, put an unhappy face. L stands for lousy. Low density lipoprotein. That's not good. That actually tends to build up fat on your blood vessels. That is associated with saturated fat, all right? Saturated fat, if you remember when we did the chemistry section, means all single bonds. So butter, coconut oil, lard, whatever. Kentucky Fried Chicken, the outside layer, the grease. All that's associated with LDLs. HDLs is associated with the Mediterranean diet, which, as we talked about already, leafy vegetables, fruit, fish, a lot of fish, nuts. That's HDL, better HDLs. So you want to try to up your HDLs, your happy fat, and lower your lousy LDL fat. There's also something known as lipoprotein A. You should get checked for that if you got any problems with your cholesterol. It's inherited, and it's apparently very bad protein, a very bad fatty protein that builds up on the vessels. Last but not least, a little bit of comments. This here should be 81 milligrams of aspirin. that is recommended for any heart patient. Sometimes they were thinking about recommending it to everybody over 50, every man, because they're more at risk of a heart attack. So aspirin thins the blood, but it's not recommended unless you have a heart condition, because there are side effects. 81 milligrams of aspirin. Beta blockers inhibit adrenaline. As we said, epinephrine, adrenaline are all make the heart beat faster. You want to wear the heart out. I told you exercising 22 minutes in your target zone. You got to figure out your target zone for your heart. As I said, 22 minus your 220 minus your age times 80% is pretty much your maximum heart rate. And that's what you should shoot for. Everyone remember the words ACE, ACE, like an ace in the hole. ACE, vitamins A, C, and E are antioxidants. Those are vitamins that are supposed to help with the heart, lessen the amount of inflammation, lessen the amount of fat deposits. That's the current theory of diet, exercise, drugs, and surgeries for the heart. So I hope you enjoyed the heart lecture. I'm going to shut down the recording and take questions. Okay.